And these cases are, I find, to be some of the most dangerous because these patients have these lingering infections, but because their bone is so thick, their anatomy is so wide, that infection can't get out. And so it sort of sits there and brews until finally it breaks its way through the buccal plate. And that's when the patient comes to the office and says, oh, I think something's wrong with this tooth. So keep in mind, these cases can be treated with a lot of different materials, but often overlooked, not really talked about that much these days, are these Cytoplast PTFE singles. And these are really, really convenient. They're very easy to use. They come with a smooth side and a rough side. And we usually suggest people use the smooth side facing the bone. And these can really be secured in such a simple fashion because, again, we're not going for primary closure. One of the benefits of using a membrane like this is that we don't need primary closure. So in terms of suturing, you just want to do something that's going to be very, very simple for you. It could be some sort of horizontal mattress or some sort of figure eight that you've seen, us do before. You could also just do single interrupted sutures. The key for me here is that we're deficient in the buccal occlusal line angle. And so we really want to make sure that when we're packing our bone, we're actually supporting that buccal occlusal line angle. And yeah, Cesaro.
There may be a question about why I use the rough side up and the smooth side down. And that's really related to the ability of the tissue to hold on to those rough bumps, those little dimples on the rough side of the membrane. And it helps the tissue stay in place.
Yeah, and that's a great point. I think clinically there may not be much of an issue if you do accidentally use the wrong side. But again, remember, we're going to be removing this membrane. This is a non-resorbable membrane. And when we remove it at a couple of weeks out, we want to make sure that, it comes out easily. We don't have to worry about giving the patients anesthetic. So as you can see here, we're getting closure here with just a continuous type of suture here, nothing really too specific. You can see here, as I'm going from inside the socket to outside the socket, that's really a great way to go because you're avoiding the risk of pulling out that membrane as you're suturing. And so that's something to keep in mind. As you see here, I started to go from outside to in and I changed my mind, went back inside to outside. I think so that's a really nice tip. These cases, in general, I like to use this PTFE sutures as well. If you're thinking about it, these patients have to return to remove the membrane anyway. I like to have that membrane in about 3-4 weeks minimum. And so it's nice to have those sutures in place for that whole period of time, just keeping everything in place. And what you end up getting with these cases is really phenomenal. You get really excellent healing. This is how the PTFE looks when we remove it. As you can see here, this patient did have a good amount of plaque and debris on the occlusal surface of that membrane. But underneath, we get this beautiful new zone of keratinized tissue that's currently maturing. As we take that membrane out, we start to see it. And
go ahead. Finish up that where you were going to say.
I was just going to say, if you were to remove the membrane a little too early, sometimes you'll see a lot of that particulate bone graft material. But this is really that sweet spot about 3 to 4 weeks when I'm removing it, and you kind of see that bleeding that occurs. And I really love to see that. And then at this point, I'll let the patient heal for about another 3 months or so, and then we're ready for our implant placement.
So what I was going to say is that with this membrane, because it's a non-resorbable membrane and it stays in for 6 weeks or so, it does allow for some plaque or otherwise food to go underneath it on the edges. And so it is important to make sure that the edges are tucked under the tissue interproximally so that plaque doesn't have an easy time of getting under it. Some of it will, and it's really not that big a deal, as you can see, but obviously it's better without that.
Yeah, and so obviously no dead space under that membrane. You want to try to keep it as taut as possible. And if you do that, and if you're patient and remove this membrane at about 3-4 weeks, like I mentioned, you end up getting this really incredible zone of keratinized tissue, but also we have really excellent bone underneath. Someone just asked a great question. Are you irrigating the area? No. Me and Israel both really tell our patients really not to mess with the area. Obviously, we want them chewing on the other side, but I'm not looking for them to help me keep it clean too much. If it's somebody that's extremely anal, I have told patients to use like a Q-tip and just remove some of the plaque from the adjacent teeth. But I really prefer that they don't put any lip pressure, any tension on their lip. Really stay away from the area. I think that's your best bet. And if they need to rinse, maybe some warm salt water, but certainly not for the first couple of days. And you can see here when we uncover this, we have plenty of bone. That buccal defect that was a dehiscence that was very localized. That was where the infection was draining from, has been completely regenerated. No particulate bone graft materials here. No particulate remnants, and really healthy bleeding bone. You can see I've been working with Dr. Putterman for quite some time now. I started using some Straumanns in these posterior cases just so I could be like him. But you can see we have really nice healing. The bone looks very uniform. And these cases come in all the time. These patients do have thick biotypes, but just because they have a thick ridge structure and thick anatomy, there's always some complicating factor. In this case, the patient had a communication with the sinus in that palatal root. So I extracted the tooth and I noticed that there was a communication. And so I want a little extra security in these cases. Again, I can use the PTFE really, really nicely here. And then this is something that I think is often overlooked because someone just even in the chat just mentioned I can never tuck it that easy. Well, the key to tucking it is not rushing, right? We have these membranes that are pre-cut, so we kind of just want to get it in there. Well, you have to take your time. You have to do a nice sulcular incision, maybe 1 tooth to 1.5 teeth either side of the defect. You want to make sure that's to the bone, a nice clean incision, and then you want to do a full thickness flap reflection or a tunnel, and you need to make sure that that tunnel is prepared wider than the size of our membrane. If you don't do that, you're going to be struggling to get these membranes in. Now, this is not a collagen membrane, so it is a little bit stiffer and a little bit easier to work with, and you don't have to worry about it tearing so much, but you really need to make sure that tunnel is prepared wide enough to house that membrane.
And it kind of goes without saying, but do not use this membrane to seal that sinus perforation. What would you use there, Matt?
So I play around with a lot of different things. If it's as small as it is here, this is where I'll go and take like a collar plug or collar tape or something like that, and just sort of make sure that that opening is not patent, and then I can pack my bone graft there. In some cases, I've used a collagen membrane or an amnion chorion membrane down there, but for a case like this where it's so small, I really just love just blocking it with some collagen. What about you?
Yeah, I would do the exact same thing. I typically use sometimes a stiffer resorbable collagen membrane to seal that off, or some type of amnion chorion to seal it off. Yeah.
Yeah, and so the trick to doing it smoothly, as someone just asked, is taking your time with that flap elevation. And you can see in this case, this patient's very thick bones. It's not the easiest thing to elevate these flaps sometimes to get over that hump, that buccal ledge there. And that's where you just have to take your time, because once that tunnel or flap is excised and elevated full thickness, and you have one clean pouch to place your membrane, it really becomes a very, very simple procedure. I typically will do just like I'm showing you here, where I'll put that membrane in first. As you can see here, I love these for these posterior cases because they're usually perfect for these molar sites. For a premolar site or for an anterior, we end up having to start trimming this membrane because we don't want it in contact with the adjacent teeth. And like Israel mentioned, we want to make sure we can tuck it right under those papilla. And so this works really, really well for these posterior sites. We'll pack it and then we'll go get closure. Now, this is something that I do quite a bit. I don't really talk about it much, but for sockets, I really love to do this. I don't really love the idea of putting so many single interrupted sutures. Obviously, you can pull out your membrane. You're also putting a lot of tension on the flap margins. You can necrose the flap. And so I'll do like a horizontal mattress. Obviously, we're not getting primary closure, so we're not looking for dual layer closure here, but it's still taking those bites further away from the marginal gingiva, less chance of necrosing the flap. And so sometimes I'll do it just like this, where I'll do a horizontal mattress and I'll tie it off. Another little trick, since I really want everything to be kind of folded over and pushing down on my membrane, is I'll do what's called a Laurel modification. So I'll actually, rather than tying this off here, I'll take this tail and I'll run it through this palatal loop. And what you end up doing, as you can see here, is you end up having two sutures in one. You have like a single interrupted and a horizontal mattress combined, and it actually is helping to push everything down, and you can see those flap edges kind of get inverted a little bit, so it's pulling down on that membrane, and I really love to do that. And then as you can see here, I'm just putting a couple of other single interrupted about 3-4 millimeters apart, just to make sure that that membrane's bound down everywhere. And this is a really predictable way to go. This is the sutures that we use for this. We always get specific questions about the size of the needle. Obviously, Israel and I don't do everything, exactly the same, but there's a lot of overlap, and this is one of those things.
One day, I hope to.
Well, me too. Let me ask you this question. I know I've asked you this before, but I forgot the answer. For your traditional ridge augmentation cases where you're using PTFE, are you using the 3.0 or the 4.0?
I'm using the 3.0 cytoplast for the horizontal mattress. Yeah.
Yeah, I find that the 4.0 is so small, and then it's so biocompatible that when you do those horizontal mattresses, the soft tissue tends to grow over it. So I stick with the 3.0 as well. And here's that case healed up. And of course, we are going to remove that membrane again at about 4 weeks. And this is exactly what you saw in the last case. Almost looks like an identical case, but it's not. And I know that because this patient hasn't been back yet. But you can see again that soft tissue looks really pretty. Some people comment that that tissue right over the occlusal, looks a little bit more immature than the tissue to the buccal and the palatal of it. And the answer is yes, it is more immature. It's newer tissue. It's not as thick. It does take a little bit of time. But I love in these cases being able to, literally the only cases that I'll do flapless, if I have a good CT, I can actually be very confident that I have good bone, buccal and lingual to where I need to be. So I think this is really something that we should think about doing. They're very inexpensive, and they're very safe. This is how we remove the membranes at about 4 weeks. And you can see there's no anesthetic given here. The first time you do this, you think to yourself, how can I do this without giving anesthetic? But these patients don't feel it at all. They're very, very easy to remove. And remember, I just removed the sutures a minute before. Now, this case is exactly what I was talking about here, where I had to remove that membrane a little sooner because the patient was leaving town for about 6 months. And I ended up going back and doing the implant a couple of weeks ago. It looks great. I posted that on Instagram, actually. But you can see here, even removing it a tiny bit early, that blood clot's still stabilized enough that it will granulate in, which is really nice.